This meeting is being recorded.
Hello, everyone, and welcome to today's webinar, Screen, Test, and Refer, the National Diabetes Prevention Program. As we begin our session this afternoon, I would invite you to head over to the chat area and comment where you are watching or listening from today. We do have a variety of participants on the line, and the majority of whom are partnered in some way with Quality Insights for the prevention and management of diabetes, hypertension, and high cholesterol for the communities you serve. Wherever you might be joining us from, we are looking forward to a full hour of great content and our special guests. Now, before we introduce our speakers, I want to walk through a few housekeeping items about the Zoom webinar platform that we are using for those of you that may not be used to using this format. In order to make sure that we can hear our presenters clearly, all attendee lines are muted. We do invite and encourage you to ask questions at any point during the presentation. You do not need to wait until the end. So we will be monitoring the chat and answering questions in the Q&A. And sorry, my dog is barking. We do invite and encourage you to enter those questions. And if we run out of time at the end of the session, we will gladly email you directly and answer anything you might have asked. So without further ado, I will now hand over the presentation to Danielle.
Thanks so much, Lori. I appreciate it. Welcome, everybody. We are so happy to have you here today. I'm Danielle Nugent. I am going to be a speaker / facilitator for you today. And along with myself, we have two guest speakers. So we are just so excited to have you here and to be talking to you today about Screen, Test, and Refer National Diabetes Prevention Program. So what we are going to be covering today, we're going to be talking about screening and testing for those at risk for diabetes and the ways in which you can be actively referring them to the National Diabetes Prevention Program. So who's going to be talking to you today? It's going to be myself, Danielle Nugent. I'm a Master's of Science. I've been a health coach and consultant for over 12 years. I've worked around a variety of topics, including diabetes and hypertension, cancer screening, patient-centered medical home, etc. I've worked with a variety of practices, but most specifically, primary care providers, FQHCs, et cetera, et cetera. And with me today, I have Kathrny Luebke, who is a Community Health Integration Program Director at the YMCA of Delaware. Kat has worked at the YMCA of Delaware for 12 years, and a little bit about her background. She started out as a personal trainer and working with special needs populations before transitioning to the Healthy Living Department, which she has been running and an active part of since 2019. Kat has been focused on increasing third-party payer coverage, National Diabetes Prevention Program enrollment, as well as helping Delawareans reduce their risk for type 2 diabetes. Our third speaker today is Dr. Megan Werner. Dr. Werner has been the Associate Medical Director of Population Health and Quality at Westside Family Healthcare since 2011. She is an actively practicing physician and has been doing so at Westside since 2007. Along with being a medical doctor, she also has a MPH and is responsible for population health and accountable care organization initiatives at the practice. She's an active member on several advisory boards, including Delaware Public Health and Medical Ethics Advisory Group, the Delaware DMMA Drug Utilization and Review Committee, and eBright Health ACO Quality Improvement Committee. These are our speakers, and we are so happy to have them with us today. For those of you that are interested in our continuing education credit, which is available for participating today, we have a couple of things. So first of all, we appreciate all our participants, clinical and non-clinical. There will be a evaluation for everybody at the end of this. And for those looking for continuing education credits, we have an evaluation that is available at the end of this webinar. Lori will come back on. She'll talk a little bit to you about what you need to do in order to get your continuing education credits. So as such, we're going to define what our learning objectives are for today. So for today, one of our primary objectives is to describe the prevalence of prediabetes, both at a national and a local level. We're going to be talking a lot about Delaware today, but we realize that not everyone on the call may be from Delaware. We might have some Pennsylvanians or some Marylanders. Just so you know, we are aware that not everybody is a Delawarean. As such, again, we're going to be talking about prevalence of prediabetes and diabetes. We're going to be identifying the benefits of the National Diabetes Prevention Program. We are going to explain the screen test and refer process. And then we are going to identify some opportunities for all of you to be able to refer to National Diabetes Prevention programs in your respective areas, whether these programs be in person or virtual. So who is Quality Insights? We are a non-for-profit organization that is focused on healthcare quality. We focus on better healthcare for everyone. We have federal and state contracts, which include contracts with the Veterans Healthcare Administration, Quality Improvement Network, end-stage renal disease, the ACA, patient navigation, COVID hesitancy. I could keep going, I won't. We strive very much to be a change agent and partner that works with local and federal organizations and collaborates to help improve care. As such, we do a lot of work with Division of Public Health in Delaware and also the Pennsylvania Department of Health. We work with over 110 clinical practices in Delaware and over 75 in Pennsylvania. We provide direct technical assistance to those organizations at no cost. And we work with them around things like diabetes, heart disease, stroke prevention, etc. For those of you interested in learning more, I highly encourage you to click the link that will be added into the chat queue to learn more about who Quality Insights is and the ways in which we partner and can partner with your organization. Which brings me on to our work today. So today we are talking about the STEM work, a piece of the STEM work, screen test and refer. And so STEM, State Engagement Model, is a project through National Association of Chronic Disease Directors and the CDC to bring about awareness, availability, coverage, and of course, screen test and refer, which are around the National Diabetes Prevention Program. It's to bring together diverse stakeholders to raise awareness of prediabetes and the National Diabetes Prevention Program and to advance the prevention of type 2 diabetes. The overall goal, increasing enrollment and retention. So I just alluded to the 4 pillars of STEM, which are awareness. So broadening the awareness of providers, of patients, of the general public about the National Diabetes Prevention Program and pre-diabetes. Availability, enhancing the availability of programs and access to those programs. coverage, making sure that national DPP programs are covered, and of course, screen, test, refer, which we are going to be focusing on today, which is all about protocol and process for enhancing referrals to national diabetes prevention programs, as well as engaging patients and providers around a pre-diabetes conversation. So I talked a little bit about the 4 pillars. Now we're going to talk a little bit about what the goals of the state engagement model are. One of the primary goals is to increase referrals to the National Diabetes Prevention Program by 10%. You'll see the end goal here of June 30th, 2022. We know that's coming right up. And you should note we are currently assessing our data to see where we are in meeting these goals. Some of the sub goals that address the different pillars, increasing provider and organizational awareness of the national DPP, increasing national DPP lifestyle change program providers, increasing the number of employers in Delaware that have committed to offering a national DPP, and of course, collaborating to develop standards of protocol to increasing screening, testing, and referrals, which we are meeting that one today, along with several other things that we have done around screen, test, and refer. So now for the audience engagement part of our presentation today. So we have a poll here that is going to pop up on your screen. And we would ask that you would answer roughly how many American adults have pre-diabetes. It should be noted, so I'll give you a little bit of a clue while we're waiting for the answers to come in, that it's roughly 1 in 3 American adults has pre-diabetes. So 1 in 3, that puts them at risk for developing diabetes, heart disease, and stroke. Lori, do we have our results?
Are you seeing the results, Danielle, or do you need me to read them to you?
I don't see them. So
okay, I thought maybe that might be the case. Everyone responded, the majority, 59% responded, 56 million. We had 30% respond, 88 million, and 3% respond, 15 million.
Perfect. So now that we've asked the question, we're going to provide you with the answer. Pre-diabetes prevalence nationally is 88 million. So the answer was C. And as you can see here, so it should be noted, this is a 2018 estimate. This comes from the Centers for Disease Control. We actually have links on the slide as to where we got our numbers. And this is essentially a breakdown of pre-diabetes prevalence within pre-diabetes prevalence nationally. And you can see one thing that I will point out is the 45 to 64 age range and how that breaks out to a higher prevalence rate. There's also a breakdown by gender as well as race and ethnicity. So as we're talking about prevalence, we want to make sure that everyone's on an even playing field about what prediabetes is. So essentially, prediabetes puts you at risk for diabetes. So again, we're talking about patients and the general public that are falling into a risk category for diabetes, but do not have a diagnosis of type 2. So it is those that are falling into a risk category, are in the pre-diabetes range, but do not have type 2 diabetes. Later in this presentation, we'll be going into detail about the different testing, the different screening options for determining whether or not a patient falls into that pre-diabetes range. And as we continue, we'll continue to sort of set the stage for what the prevalence is. So now we're on to our second polling question, and this one is about prevalence in Delaware. And again, we understand maybe not everyone here is from Delaware. Maybe those of us from Delaware still aren't sure about the answer. That's okay. We would ask that you fill out our chat queue asking about how many Delaware adults report being told that they have prediabetes. I'll give everyone a little hint again. This number of people could fit into the Blue Rock Stadium, which is the stadium in Wilmington, 11 times over. So it's a significant amount of people.
All right, Danielle, 57% answered 11.8%.
I love it. So all of you have been doing your homework. It is 11.8% of Delawareans report being told that they have prediabetes, which works out roughly to about 75,000 Delawareans. And again, if we were to try and cram all of them into the Blue Rock Stadium in Wilmington, we would have to do it 11 times over. So along with that 11.8% number, we have some other statistics here that talk about some other things that factor in to our pre-diabetes ranges, which include pre-diabetes and diabetes cost, which costs the state of Delaware over $1 billion each year. The amount of Delaware adults diagnosed with diabetes jumped from 8% to 13% from 2003 to 2019. And then, of course, the correlation between obesity. So roughly 34% of Delaware residents are being reported as obese. The obesity prevalence by county breaks down to, so it's 34% for the state, and then it's roughly 31% for both Newcastle and Sussex County, and Kent County coming in at 42%. So regarding risk factors, we talked about over the age of 45 when we looked at the prevalence rate nationally. Those of us that are not physically active, those of us with a family history of type 2, those with high blood pressure, those with a history of gestational diabetes, and again, that linkage to being obese. And also we have some connections to those of certain ethnic and racial backgrounds that can be linked to a higher risk for pre-diabetes. Okay, so on to our third polling question. Participation in the National Diabetes Prevention Program can lower risk of developing type 2 by as much as 58%. Is this true or is this false? If you were to participate in a national DPP, are you then lowering your risk by 58%? And in our next slides, we're going to be talking a little bit more about prevention and why prevention is so very valuable.
All right, Danielle, 93% of our attendees today answered true.
I love it. Everyone's so very smart. It is true. Prevention, as I mentioned, is one of the ways that we focus on for helping to reduce pre-diabetes. So healthy lifestyle choices can help prevent type 2, which in turn helps to get people out of that pre-diabetes range, right? So later in our presentation today, the data points that are mentioned, that 58 to 71% and the 71% and over 65. Kat Luebke will be talking about the study that was done and sort of the validity and reasoning behind some of those numbers. So I'm going to gloss over that for now, but know that later on Kat will be talking about it, and instead focus just on what the predictors of prevention are. So healthy lifestyle, right? We know these things. Eat healthy foods, be physically active, lose weight, take medications as prescribed. Those types of things have an active effect on patients that are falling into that pre-diabetes range. So we really want to focus on prevention. And today we're going to be talking to you more about the National Diabetes Prevention Program and how that program addresses these factors. So what we're going to be jumping into today is the steps of screen, test, and refer, which are educate, define eligibility, screen, test, and refer. So first and foremost, we're going to talk to you a little bit about educating the care team. The value of educating staff is getting them on board and knowledgeable about what prediabetes is, why it's valuable to have a conversation with your patients about it, and what the resources are available to combat it. So the value of the prediabetes conversation, it helps to increase patient awareness, helping to lower rates of diabetes, etc. One of the biggest discrepancies we see in referring patients is they are not always aware that they have prediabetes. So if our providers aren't having the conversation with patients and letting them know that prediabetes is a thing, that they're falling into a prediabetes range, then patients are unaware. So it starts with educating staff. It starts with staff being aware of prediabetes and being able to have the prediabetes conversation. Again, in this slide, you'll see links to several tools and resources. Here, we actually have some resources around the prediabetes conversation. We have some more tools around the National DPP Coverage Toolkit, being aware of the National Diabetes Prevention Program, which again, Kat will be speaking about later. Along with that, we also have some quality insights tools, which can be very valuable to you and your staff, which includes a prediabetes module that has a plethora of resources, links, and it has things for everyone from clinical to non-clinical staff. We have the National DPP Coverage Toolkit overview. We have a DISCO eLearn series, which is free education around prediabetes, and we welcome you to check any of these things out. So I talked about, so educating staff essentially is the first step, right? So staff need to be aware of what prediabetes is, what the National Diabetes Prevention Program is, so that then they, in turn, can educate patients. Again, we want to make sure that we are defining prediabetes, that we are providing patient education resources, and meeting patients where they're at with language needs, also with, so we have videos, we have things in English and Spanish. We talk about the use of small media and the ability to help guide patients. Patient portal is valuable. We know more and more that practices are looking at utilizing the patient portal as a way of connecting with their patients and being able to get out materials, education, and things of that nature. We find that text messaging is another way in which to have better patient engagement. Not everyone is good about checking their phones and voicemail, and the world is changing, our technology is changing, and therefore we are doing our best to adapt with that. So we have seen that text messaging is a valuable way to engage patients around a variety of topics, including prediabetes. So here we have the define eligibility step. So we've educated our staff, we've educated our patients. Now how do we define the eligibility for who can participate in a national diabetes prevention program? This is the step where we are determining which of our patients is eligible for the national DPP. Which again, this program is targeted towards those over the age of 18 that do not have a diagnosis of diabetes, again, are falling in that pre-diabetes range, but fall into criteria that puts them at risk for diabetes. So for example, over 18 and obese. And here you see the BMI calculations. And again, Kat will be talking a little bit more about this criteria, so I won't go too far into depth on it, but what I will say is that you can utilize this criteria as a provider practice to set parameters for running a report to determine which of your patients you should be outreaching to. Which brings me to screening. So the first thing I will say is that screening is an excellent option for those at community-based organizations or those out in the field without the ability to run reports or do clinical testing. We'll be talking about testing later, but when it comes to prediabetes, a screening tool that we recommend is the prediabetes risk test. So if you are doing outreach out in the field, or if you are a community-based organization and you don't have an electronic health record, the prediabetes risk test can be utilized to help assess whether or not a patient falls in the pre-diabetes range without having to do any blood glucose testing or looking at their medical record. We also want to encourage clinical practices to use ICD-10 codes for prediabetes. So as you are having the prediabetes conversation with patients, as you are determining where patients are at with prediabetes, we want to make sure that you are coding for that so that then again, you can run a report. So Lori, we are running short on time. So I think I'm going to jump through the polling question. So essentially, we were talking about the prediabetes risk test. And here what you will see is that the prediabetes risk test, you need a score of 5 or higher. And again, as I mentioned, this is a great screening tool. It goes through it discusses age, it discusses previous history, etc. And in order to be referred, so you want a 5 or higher on the prediabetes risk test. So this next polling question, and again, because of time, we're going to skim through it a little bit, is around the steps of screen, test, and refer. So which one includes information on the guidelines for blood glucose measurement? So we talked about screening. Now we're talking about testing. And this is where it gets specific. This is for those with electronic health records and the ability to look at patients' medical charts because it is about testing patients' blood glucose. Here we have some guidelines from the ADA and the AMA around testing procedure. There are active links here if you want to dive deeper into them, if you want to look at how you can adjust them to your practice. And here we have the different types of testing. So we have the A1C, we have the fasting plasma glucose, we have the the plasma glucose test after 2 hours after glucose load. And here we have, if we look in the prediabetes, we see the ranges for these tests. And of course, the referral piece. Which brings me to the referral piece. So along with testing, one of the biggest things that we want from today is for you to be aware of prediabetes, aware of prevalence, and actively able to refer to your local national diabetes prevention program. So here we have links. This local national DPP link will take you to a finder where you can put in your zip code and look for national DPPs that you can refer to in your area. We have a patient referral form example here for you to use. We highly recommend the use of things like script pads, or if there is a national DPP that you are choosing to refer to, such as the YMCA of Delaware, utilizing their referral form, which we have linked here. We want to, again, encourage people to run reports in the electronic health record and identify eligible patients, to use that pre-diabetes ICD-10 code, and then to actively be referring. Quality Insights can assist practices with this. So if you're connected with us or would like to be, please reach out afterwards. We can assist with referral letters. We can help with the patient portal, email, text campaigns, etc. when it comes to helping you connect your patients to the National Diabetes Prevention Program. So with that said, that is my piece of the presentation. I am going to bring it over to Kathrny Luebke, who is going to talk to you more about the National Diabetes Prevention Program. Kat?
Thank you, Danielle. I'm here today as a provider of the National Diabetes Prevention Program to give everyone an idea of what it is to actually participate in the program, as well as how you can refer your patients directly into the YMCA's Diabetes Prevention Program. So first, I want to let you know a little bit about what diabetes prevention looks like. So on the next slide, you'll see that it's a modest amount of weight loss. The program goal is 7% weight reduction. It's a little bit of physical activity. It's at least 30 minutes of physical activity 5 days a week, with the program goal being 150 minutes of physical activity per week, and then understanding their blood sugar numbers. So it's one thing to go and have routine blood work. It's another thing to look at that and then have a meaningful conversation with the healthcare provider about what those blood values mean. We'll take a look here, as Danielle had mentioned earlier, that research study. So this was done by the National Health Institutes. And they actually had 3 control groups in this study. So they had a control group that went through a lifestyle change program. They had a control group that went through using metformin, so they used medication as a preventative measure. And then they had a group that did absolutely nothing. So these are the results from that study, and they actually looked at the participants 2 years after they completed the program. So to look at somebody 2 years later and find out that 58% of those people did not develop type 2 diabetes is pretty huge. And then with the senior population, it being even higher, that 71% did not develop type 2 diabetes. And as we know, age is a risk factor for type 2 diabetes. So that's pretty significant. When we compare it to the people that were put on metformin as a preventative, only 32% of those people did not develop type 2 diabetes. So the lifestyle change program is more successful at reducing risk factors for type 2 diabetes than taking medication. And we'll see a little bit about if prevention is working or not. So this is a little scale here. I know it's tiny and I apologize for that. But you can see in about 2010, 2009, the new incidence of type 2 diabetes really spiked. And then we start to see this nice decline. And it's no coincidence that in 2010 is when the National Diabetes Prevention Program was really launched nationally. And across the United States, the Ys were a big part of that because we are a great community resource in order to deliver community health programs like the Diabetes Prevention Program. So we start to see that nice downward slope. So prevention is working. So Danielle already mentioned a little bit about the qualifications. The diabetes prevention program does have specific qualifications that patients need to meet. So it is for adults. They cannot be pregnant because part of the program is tied to weight loss. So if somebody who is pregnant, they're naturally going to be gaining a little bit of weight. This is something great for a woman to start after the pregnancy. Again, tying to that weight loss goal, because that's really where the prevention kind of kicks in. They do have to be overweight. So we're looking for that BMI of 25 or higher, or 23 or higher for Asian individuals. And again, we're focused on prevention. So the individual cannot already have a diagnosis of type 1 or type 2 diabetes. Or if they're Medicare beneficiaries, they cannot have end-stage renal disease. So if we can check off those 4 boxes, we're going to assess if they're at risk for pre-diabetes or type 2 diabetes via either the CDC risk quiz, as Danielle has mentioned, or through their blood glucose values. And we're going to take a look at those next. I'm just going to recap these again because I know we've seen them once already. But we're looking for that A1C value of 5.7 to 6.4. This is on our next slide.
Sorry.
Thank you. That's okay. The fasting glucose of 110 to 125. Medicare beneficiaries, it's a little bit of a smaller range because Medicare likes to have their special rules. So it's 110 to 125, and then that 2-hour glucose of 140 to 199. As long as these blood values are from the past 12 months, they would help qualify the patient for the diabetes prevention program, or a female who has any history of gestational diabetes, that would help qualify them for the program. If you're in kind of that screening event, we're going to use the CDC pre-diabetes risk assessment, which again kind of goes through their age, their family history, their weight, to assess their risk for that. And we actually have an interactive one on our website that you can basically, they can go through, answer yes or no to the questions, and it pops out with their score. So once we know that they're diagnosed and they're in the program, this is what a patient is going to experience. It is a classroom setting, so we are doing them both in person and virtually right now. They are still live classes, so they're not a self-paced program. It's led by a trained lifestyle coach who is there to really mentor them and guide them through the program. The program is 1 year. I always like to remind people that their risk factors for type 2 diabetes didn't show up overnight. They're not going to go away overnight. We live in the world of Amazon Prime, where we expect things tomorrow. So we just kind of have to remind people that behavior change is going to be slow and gradual, and that is really the way the program works. So those in that year, they attend 25 one-hour sessions. So we start them off weekly. So for the first 4 months of the program, they're going once a week. Then we taper them off of that group support a little bit, and they're going once every other week. That takes them to the halfway point of the program. And then after that, they're going once a month. Our goal is to help the participants reach the program goals of the 7% weight loss and 150 minutes of physical activity in those first 16 weeks, and then either help them maintain it or surpass it with it throughout the rest of the program. Each one of those 25 sessions does have a specific topic that they go over and discuss as a group. And it ranges from healthy eating to their physical activity to their behavior modification. And there really is a session for everything. There's a session for going out to eat. There's a session for what you do when you make a mistake. There's a session, the first 4 sessions are really all dedicated to nutrition and understanding, balancing out their diet. All right, so here's the fun part. So since our participants have a physical activity goal of 150 minutes of physical activity per week, and we happen to run gyms, we give our participants a free family membership to the YMCA of Delaware. They are a full member. They can attend any of our 7 branches here in Delaware, and they have access to everything from the child care to the saunas to the group exercise classes. And then after those first 4 months of free membership, they can continue to stay with the Y at a discounted rate. So they would get 50% off whatever membership they choose. So that's a huge benefit that we're giving to our participants to help them achieve the program goals. So I do have a little incentive, and I have a monetary incentive to back it up. So I am looking for at least 2 healthcare providers to engage in a provider direct referral system. You would work with myself, you would work with Danielle and her team at Quality Insights. So you have a lot of support to do this, and you would get a lot of more hands-on support from us as far as the referral process, getting referrals over to us, getting direct feedback from us. How is your patient doing in the program? You know, I just was looking at one the other day, she lost 35 pounds. So being able to report that back to the healthcare provider is really some key information. So if you're interested in that, you can either contact myself or Danielle, and we'd be happy to talk to you about what that can look like. All right, so we're getting to that refer part. So we have several ways that we actually accept referrals here at the YMCA of Delaware. We have this lovely piece of paper. So if you like to fill out a form and fax it, you can do that. We have a fax number listed on our website. We have an online form that you can fill out that just was dropped into the chat box that you can put in the patient's information as well as even their blood values. As long as you have your patient's consent, and you can send that over to us. And then we also have the ability to set up referrals directly into our essentially EHR. So that takes a little bit more work, but we're more than happy to support you through that as well. All right, well, hopefully that gave everyone a glimpse of what the program is, what it looks like for the participants to participate. And again, I'm looking for at least 2 practices that want to do a more engaged referral project with us. There is my email. That is the best way to get a hold of me, because sometimes I'm in the office, sometimes I'm out in the field. But I want to thank you for your time.
Thank you so much, Kat. We appreciate it. All right, Dr. Werner, your turn.
All right, awesome. Thanks so much, Danielle. So as Danielle said, I am Megan Werner. I am the Associate Medical Director of Population Health and Quality here at Westside. And I'm going to talk a little bit about our experience at Westside with referring to the National DPP. So first, I'm going to tell you just a little bit about Westside Family Healthcare in general. So Westside Family Healthcare is a federally qualified health center that was established in 1988 on the west side of Wilmington with a couple of exam rooms and fewer than a handful of full-time employees. Over the past 30 plus years, we've grown to have 5 locations in Newcastle and Kent counties, as well as a mobile health unit that goes to farms to provide medical care for farm workers in Kent and Sussex County. Throughout that time, though, our mission has stayed stable, which is to improve the health of our communities by providing equal access to quality health care, regardless of ability to pay. Westside serves over 27,000 patients annually. Of these patients, 45% are Medicaid beneficiaries, 30% are uninsured, and most have incomes below 200% of the federal poverty level. Over 400 of our patients are best served in a language other than English as well. So that provides some of the context in which we see our patients. It's really important to keep that context in mind when we're developing care plans for our patients, because if we come up with something that's not reasonable for them, it's just not going to work, right? We're not going to get to the goals that we want to meet. Like every other primary care practice, screening for and treating diabetes is part of what we do day in and day out, because a significant number of our patients do have diabetes or pre-diabetes. So of our patients, more than 13% have diabetes already diagnosed, and we're likely to see more in the future because 8% of our patients have a diagnosis of pre-diabetes and 36% have a BMI that's in the obese range. Diabetes and prediabetes can be really challenging conditions for our patients to manage. They don't always feel that they have it, especially with prediabetes, there's not symptoms, so it can be easy to ignore. It can also be really hard to change entrenched patterns of activity or inactivity, lack of activity, to change eating habits, grocery shopping habits. It can be difficult to figure out how to make healthier choices on a budget. And it also can be really hard to make changes if other people in your household aren't interested in making those changes as well. So it's important that when we're talking with patients about managing their diabetes, their prediabetes, that we have tools that can help them to be successful. So some of the tools that we use at Westside to address diabetes and prediabetes are our staff. We're really lucky to be able to use a multidisciplinary approach internally to help manage these conditions with our patients. We do have registered dietitians and a certified diabetes educator. These folks can go through and really sit with patients, talk in depth about what they're eating, those choices that they're making, talk about their activity levels, how that can impact their blood sugars, things like that. So that's a really great benefit for our patients. We also have nurses who can do care coordination, help patients with managing their diabetes in between their visits with their clinicians. So if it's appropriate for them to be checking their blood sugars, help make sure they know how to do that, know what to do with that information, help connect them back to their clinician if it's time to adjust their medicine, things like that. And then of course, our clinicians are integral to developing treatment plans, setting goals with our patients, and then helping make sure that they have the tools they need to get to those goals. In addition to the internal tools that we use, we also use external tools, things like the lifestyle change program, including the national DPP. We know that for some people that individual counseling is the most effective strategy, but some people really, they want a group. That group provides the support that they need, and they need that structure. And so that's where things like the national DPP come in. There are sometimes barriers that we see when we're thinking about things like those external tools. So it's important that we work with our patients to overcome those barriers. Some of the barriers that we see are systemic barriers that affect all of our patients, and some are more individual patient barriers that we need to think about strategies to address. Systemic barriers include things like patient awareness of the national DPP, patient engagement, and provider engagement. Patient awareness of the national DPP is sort of the place to start, right? We want to make sure that patients know what they're getting into, because otherwise when we're talking about it, they don't necessarily pick up on that strategy. So we really want them to get a sense of what this looks like. We also know that sometimes this is a great way, giving them things like the flyers that we get from Quality Insights is a great way to start that drip of information, which helps to move patients along that continuum of action. Patient engagement is also really critical. It's much easier to tell patients to do something than it is for them to actually follow through. So we've partnered with Quality Insights to do things like letter campaigns, and then importantly, the follow-up phone calls to help patients learn more about the national DPP, assess their interest, and then help them get signed up. We also have Westside staff who follow up with patients who express interest in the national DPP, and together these teams can help move patients from that, that contemplation stage through to that preparation and action, so that they're ready to really jump in and start with something like the national DPP. Provider engagement is also really important. We need our providers to be educated on the importance of treatment, on prediabetes in general, the importance of diagnosing it, because we know that if providers are making recommendations to our patients, then that recommendation holds a lot of weight. So we have provided education to our providers on prediabetes with the help of Quality Insights, which helped our providers be aware of these resources that are available to our patients. We have focused primarily on our nutrition providers, because we know that our nutrition providers are spending significant chunks of time with our patients, talking through what they're eating, what they should be eating, different ideas, talking about their activity, and talking with them about the challenges that they might be having. And so they're in a really good place to notice if the national DPP might be a good fit for this patient, and then they can make those referrals. In addition to those systemic barriers, we want to work with patients to address the specific patient barriers that they come across. So things like language. As I mentioned, many of our patients prefer to receive their healthcare in a language other than English, and the majority of those patients prefer to receive their healthcare in Spanish. if we had patients who spoke Spanish who were interested in the national DPP, it was just hard to get them access to the program because the classes were taught all in English. So through the state engagement model, we started having conversations with the YMCA of Delaware. And lucky for us, starting in 2021, the YMCA began offering classes in Spanish, which has been a great fit for our patients. And we've been referring our Spanish-speaking patients to it ever since, which has been fantastic. In addition, starting in 2020, like many things with the pandemic, the national DPP classes went virtual. And one of the kind of, I guess maybe it was a surprise, maybe not so much of a surprise, one of the things we learned through that process was that by offering virtual classes, now all of a sudden the program was open to patients who previously weren't able to access it, whether that was because of transportation challenges or because it was challenging for them to travel, to take that time away from their families, to go to the class and then come back. So now with the virtual classes, we realized that this is an option for patients who couldn't do it before, which has been great. Cost is also a barrier that we want to keep in mind. Although there is coverage through Medicaid, Medicare, some private insurers for the national DPP, there are patients who are uninsured. And so for them, we've been lucky enough to get to work with the YMCA of Delaware through some grant programs that then covered the cost of the program for patients. Another way in which we've covered the cost of the program for patients has been through the Wise Woman program. So for those of you not familiar with Wise Woman stands for the Well Integrated Screening and Evaluation for Women Across the Nation program. So this is a program that's open to women aged 40 to 64 who qualify for screening for life, meaning that they're either uninsured or underinsured. The program helps them identify their risk factors for heart disease and then develop plans along with their clinicians to address those risk factors through visits with their provider, labs, things like that. It also connects them with a health coach, which I think has been one of the biggest advantages of the program for our patients. And this health coach helps to educate them on heart disease and also helps to promote healthy behaviors through the coaching and through enabling participation in various healthy behavior support programs. The coach helps them figure out which one makes the most sense for them, helps them get enrolled, and then really helps to give them support as they're doing it, which helps them stick to it. The materials and the coaching are available in English and in Spanish, which is great. The majority of our participants have been Spanish speaking. So far through the Wise Women program, we've referred 8 women to the national DPP. And I just want to take a minute to tell you about one patient story in particular, because it's just so exciting to see how successful this has been for her and how successful she has been in making changes in her life. So far, she's completed 8 classes. She is taking the Spanish language class. She will tell you that it was really challenging in the beginning. She had a hard time getting going. But once she got going, she was motivated to continue because she started to see changes that helped her understand the value of the program. She was losing weight. She lost 15 pounds so far. She also got to see improvement in her labs, which made her whole healthcare team really happy. And I think maybe even more motivating than those changes in her own health was that she saw how this was able to, she was able to bring her daughter with classes to she was able to bring her daughter with her to the gym to start exercising. And then her daughter started to adopt healthy habits as well. So her daughter started to lose weight, to eat healthier. I mean, and what parent doesn't want to see their child be healthier and have better health outcomes? So she was really motivated by seeing how this program could help and how it could really help her whole family make those changes together. So when I think back on our experience with the national DPP, we've learned a handful of lessons. One of these is that repetition and persistence are key. It can be difficult to engage patients in these kinds of programs. And they're not always ready at the time that we first start talking to them. So we need to bring it up again and maybe again and again. and work with them to identify, is this going to be a good fit? Might this be a good fit in the future? And just keep talking with them till we find the thing that's going to work for them. They need to know that we're here with them along their journey, and we're going to stick with them until we figure out what works. It's also really important to take advantage of their interest and momentum in the moment that they bring it up, right? Because there's lots of competing interests, lots of competing demands on people's times. So if they're in a moment that they're thinking like, now is the time that I'm ready to make change, we need to jump on that. Because if we delay, if we don't get them signed up right away, they might kind of move on, or they might realize that there's an obstacle that is now going to delay. And they're like, oh yeah, I'll get back to it. And sometimes, they don't get back to it, or it's years before they get back to it. So we really want them to jump on it at that moment, because then if they've started and they're seeing those changes, like the patient that I talked about, they're much more likely to continue. It's also really important to have continuous engagement with patients. We have found both, especially through the Wise Women program with the National DPP and with other programs that we've done, if we keep talking with people, then they're much more likely to stay engaged in the process. Addressing barriers is essential. So we can't address barriers unless we ask about them, right? So we have to start off by assessing what barriers exist, and then figuring out how we can help patients overcome them, whether these are knowledge, financial, language, other barriers, whether they're related to the social determinants of health or related to something else. We want to do that, because if we propose a plan to patients that doesn't make sense for them, that they either can't do or that they're just doesn't meet their interests, they might yes us, right? Say, oh yes, I'll do that. But they're not then going to do it, and then they're not going to get the goal that they're looking for. In the future, we at Westside hope to build on the experiences that we've had so far. We want to continue to do the things that we have been doing, like the patient and provider education, using the Wise Women program to refer patients and continue to provide that all-important coaching and encouragement, to expand our letter campaign to patients who are best served in Spanish. And then also through our work through the Screen Test Refer state engagement model group, to think about implementing a team-based system to identify, educate, and refer patients to the national DPP. Right now, we're relying mostly on our providers, and we know that for a sustainable system, we need to get more people involved. And so that's our plan for the future. Thanks very much for everybody's time. It's been great to get to share our experience at Westside with all of you.
Excellent. Thank you so much for that. We greatly, greatly appreciate it. And I feel like I learn something every time you and Kat talk about the National DPP and about lessons learned. So we greatly value both of your time today. So what I would like to do now is just to bring everyone back to focus on a call to action. So what we are asking from participants today are a couple of things. So for everyone, whether you are a provider, non-clinical, a community-based organization, everyone to work on increasing awareness of prediabetes and the National Diabetes Prevention Program with those that you work and serve in your communities. We want to focus on employer coverage of the National Diabetes Prevention Program, and also of the availability of National DPP. So again, for anybody interested in learning more about referring, becoming, any of those things are in the National Diabetes Prevention Program, please reach out. We'll have contact information available. The whole purpose of today was to focus on that increase in screening, testing, and referrals. And for those of you that are providers or part of a care team on this call today, we want to remind you, prediabetes conversation is very, very valuable. It really helps to level set what prediabetes is and why it's important to be aware of it. Utilizing that ICD-10 code, again, helps make it easier to search for your patients, to figure out which of your patients have prediabetes. And again, please, please, please refer your patients to a National Diabetes Prevention Program. And if anyone would like assistance with setting this up or greater discussions about workflow, Quality Insights would be happy to partner with you on this. So quickly, we would love to know, what are your goals for increasing screen test refer within your organization? So if everyone would just put their responses in the chat queue, this won't be a poll. So if you would type into the chat queue between now and June of 2023, what are you looking at your organizational goal for increasing national diabetes prevention, the National Diabetes Prevention Program? Is it 0 to 5, 6 to 10, 11, 15, 16 to 20, greater than 20? If you would please put those in the chat. And in the meantime, and I'll go back to it in a second, but I'm going to pass it over to Lori, who's going to talk about next steps for continuing education credits.
All right, thanks, Danielle. So in order to receive your free CME credit participating in today's presentation, you will need to complete an evaluation and also a post-test. And the post-test, you will need to score at least an 80% on that test. Once you successfully complete it, a message will be displayed that will include a link that you can copy and paste to complete the certificate and then download or print it. For those of you attending the live session today, when you log out of today's Zoom session, you will automatically be redirected to the evaluation. A live link to the evaluation will also be posted in the chat, or you can scan the QR code that you see here on the slide with the camera on your phone, and that will take you right to the evaluation as well. We'll be sending out an email following today's webinar to everyone who registered. We will include those links in that email as well, and also a copy of the slide deck from today's presentation. If you have colleagues or support staff that weren't able to join us today, the recording of this presentation, as well as the continuing education credit, will be available on the Quality Insights website. We do encourage you to visit our website at the URL that we on the next slide, Danielle. Great. We have a ton of information, resources, educational materials related to hypertension and diabetes control and prevention. We also invite you to connect with Quality Insights on social media platforms such as Twitter and LinkedIn. And there are links on the slide here that will connect you to both of our social media platforms. With that, I'd like to thank you so much for joining us today. And a special thanks to our speakers, Danielle, Kathrny Luebke, and Dr. Werner, for sharing such valuable information and insights related to the National Diabetes Prevention Program and the pre-diabetes screen test refer process. We hope you have a great rest of the day. And that concludes the session.